great. Hello, everybody. What I'm really thrilled about is that these sessions are getting videotaped. So thank you to the Judy Nicholson Foundation for inviting me here, and also for the move that you've made to videotape them, because online these videos are going to help a number of people, and they may be watching them at 2 a.m. in the morning when they can't sleep. And this is good, solid information. Well, the other talks, maybe not mine, but good, solid information that patients can read and listen to and get real help. So I was asked today not to talk about clinical trials and the work on the NCI task force, but just from the perspective of somebody who's had kidney cancer for a ridiculously long period of time, and anything that I might have learned from that experience that I could share that would be helpful. So I call this Challenges and Solutions, my ongoing journey living with kidney cancer. I'm way beyond the point where I think I'm fighting with kidney cancer. We're just living, we're cohabitating, and most days we get along okay. This week we had a bit of an upset, but we'll keep going. So my story so far, it starts like a ridiculously long period of time. I don't have a picture when I was 14, but I had my kidney removed when I was 14 years old, a full kidney taken out for what was then just known to be a rare papillary tumor. And I heard the words after 5 years, you're good to go. You know, your tumor's gone. You don't have to ever worry about this. And so who wouldn't believe that advice? I went along and had 2 children, had a great life, but 22 years later, my kidney cancer came back in a very big way, widespread metastasis throughout the abdomen, and that looked like a very poor prognosis. So everything I read sort of suggested maybe 1 year. That was 1996. So if you can do the math, that means I've been metastatic for 22 years now, and it has not been without its challenges. So I have done a couple of clinical trials. I've done 9 bits of surgery altogether. The surgeons are my best friends. And I've done some stereotactic radiation, and I've had a team around me that's really helped to guide the decisions. But I'd like to say that I'm mostly making my own decisions at this point forward and managing life. The pictures there were once when I was on a study at the NIH, a clinical trial at the NIH in Bethesda. A friend took a picture, and then just this summer I was back in Washington, and I said, take the same picture because the patient is getting older, and that's a good thing. So I celebrate every birthday. So what I'm hoping to cover today that might be helpful to other people, to go from the shock of diagnosis, and this will segment a little bit from the last talk we heard, and the sense of, you know, I've got to get it out and got to get it out tomorrow. And then what the patient can do to get the best care around them. I have to talk about clinical trials because I believe in them so passionately as the way forward. Some thoughts about shared decision making, about making sure the patient is making decisions. And then I stole the top 10 tips for kidney cancer survivors. These are not my personal tips, but I stole them from Kidney Cancer Canada, and they were approved by the Medical Advisory Board, so there's not going to be anything radical that tells you to take crazy supplements or anything like that. These are just solid recommendations. So from my personal experience in 1974, it was pretty obvious. You whip that kidney out, and so that was it. There wasn't much of a decision to make. I was only 14 anyway, so I just did whatever the doctor said, which is no longer quite the way things work. But in 2018, patients have many, many options, as we've just heard, that you don't have to have a radical nephrectomy in many cases. So partial nephrectomy, the AS means active surveillance, maybe a radical, maybe ablation. But the important thing here that I want to make clear is that a diagnosis of kidney cancer may feel like an emergency, but it's rarely a medical emergency. And so I wish that every urologist could hand their patient a pause button to say, you don't need to make a decision about this today, tonight, or in the next couple of weeks, you've got a little bit of time to think about this, because in most cases, that tumor didn't come up overnight. It's been steadily growing for years. And so you've got the time to think, and to think about how you might want to approach things. And as always, is there a clinical trial for me right now? Is there a clinical trial for me before surgery? There are some, and they might be worth investigating, but you can't investigate those kind of trials when your kidney cancer is already in the pathology lab. So you need to take the time. And I think those of us who are online with other patients, we feel and we hear their urgency, but if we could just get across the message that you can take a deep breath and take a couple of weeks and really think through and maybe get to a different center for a second opinion. I would say a center that has a high volume of kidney cancer patients, then you might get a different opinion. And you won't regret taking that 2 weeks in the long run. Did I miss one? No. So that was it from the shock of diagnosis. And I think for many patients that I'm in touch with, it's if and when the kidney cancer comes back. That's actually the bigger shock. That seems to be more of a betrayal. And in part because, some very well-meaning urologist told you that they got it all, and that you weren't going to see this disease again. And so in my personal experience, when my disease was widely metastatic in '96, there just wasn't much to choose from. The options were all terrible. So I could have had interferon, I could have had IL-2, but those were both no's for me because I have a papillary kidney cancer. And so I searched. There wasn't much literature. There's still not much literature that those would have done any good. And so I made friends with a surgeon, and I've had surgery after surgery after surgery. And he said, we're going to keep doing this until better drugs come along. So, but if we fast forward to 2018, there's many treatment options. It's really hard to keep track, really very hard to keep track of what's available today because it's changing every couple of months. So with so many new drugs, I think we're at 13 that are FDA approved and many, many more in clinical trials. So the decision making is actually harder than it used to be when we only had 1 or 2 drugs. So a tip that I have found for other patients is to build yourself the very best team. And the first part of that may be inconvenient, but you may have to leave your local friendly doctor whom you love so much and go to a bigger center. So in my case, doctor number 1, who had done, my first or maybe even my second surgery, I realized that there were lots of questions I had, and he was a general urologist. He did not have the expertise that I needed, especially with a rarer type of kidney cancer. And the answer to my questions a lot of times was, well, we just don't know. And I thought, well, I need to find somebody who can answer more of my questions. So what I've created is my concept of a medical home. So my care is a little bit scattered in places, but I have declared one of the cancer institutions is my medical home. And then sometimes I leave home for a short period of time, but I come back to ground zero or medical home. And that's where I have my medical oncologist. And he mostly thinks that he's in charge. And then I go elsewhere if I need to for a surgeon and for a radiation oncologist, a really good psychologist, not a general psychologist, but somebody who works with cancer patients specifically, a fantastic nurse, and me, that I've put myself on my medical team. So I have to travel a couple of hours into Toronto, which is inconvenient, especially in the winter, and people say, well, why don't you get your CT done locally? It's because my medical home is in this big cancer center, and it's important for me to keep all of my records together. This funny-shaped bed that you're looking at is not just how Canadians treat patients in hospital. I don't know if any of you know what this is, but I called this my blue canoe. This is the form that they give you when you have stereotactic body radiation therapy, so SBRT. You lay down and they blow this thing up around you and it gets kind of hard. It's a body mold. and then you lay in it. And I had 5 sessions of SBRT, and I will say in terms of treatment options, it was the easiest thing I've ever done. And I had that done to take care of a lymph node that would have just been really big surgery. So we just decided to zap it, and that was the blue canoe. And I posted about that when I was having that treatment done, but that was kind of easy to do that. So in terms of shared decision-making, with the IKCC, the international group, we've written a publication, a book that's called My Treatment, My Choice, where we're really trying to promote patient values in making the decision that it should be your choice, not necessarily your physician's choice. Hopefully you'll agree, but ultimately it comes down to your values. So a physician might say, well, this is going to be well-tolerated treatment, because they believe that, and that's what the data said. But in my own personal experience with one of the TKIs, grade 2 diarrhea that doesn't ever go away is not very well tolerated. If you're having 6 or 7 bowel movements every single day unending, that's not very well tolerated. So I had a different impression of that and said, well, I won't do that again. So just bear in mind, it's going to be individual, and you will weigh up the risks and benefits and how much risk you're prepared to take, and maybe it changes throughout your life. So when I was 36 and my children were young, I was taking on lots of risk. And now that I'm 58, I'm really focusing more on my quality of life and can I do less treatment. So the bottom graphic says, you can have quality and you can have quantity of life. And we all want it all, but if you can't have both, where would you put your preference? Are you going for the maximum number of years? Do you want to live to be 100? Or do you want to live 5 more years with really excellent quality? And maybe we get both, but of course, those are tough decisions. So our guide for My Treatment, My Choice, which is online, is just a guide for people to think through what's important to you versus what your doctor's last patient might have been thinking about. And then always with clinical trials, I wish we had just an automatic response for every patient whenever there's a bit of news of asking, is there a trial for me right now? If every patient kept saying, is there a trial for me? Is there a trial for me? Then the physicians would certainly know that patients were interested in trials. All of the studies we've done tell us that the vast majority of patients are never asked. So maybe we need to get more patients asking about trials. And why I believe so much in clinical trials is that this is the way to access tomorrow's treatments. That the trials we have now may not get approved for several years yet. So, and sadly, it's just such a few patients participate. The numbers in the US, by the way, are much lower. So in the US, it's something like 2 to 3% of cancer patients are on trials. In Canada, where I live, it's 15 to 18%. In Europe, it's much, much higher. So what's going on here that we don't have enough US cancer patients signing on to clinical trials? What's specific? So that's a whole other discussion. And I know a charity called Cancer Care did a study that essentially said that patients just don't have enough information about clinical trials. So lots of discussion we could have there. Cancer.gov is an excellent resource with lay summary information that's prepared by your government. And of course, clinicaltrials.gov, but you almost need a PhD to navigate that site. But somebody can help you find a trial through there. So do think about clinical trials. I think the myth out there is that patients think, I'll do a clinical trial after I've done everything else, when the real truth is you'll have more options right up front. Do the clinical trial first and do it second, and then sometimes it gets a little tougher to find trials. So why do you need to ask here? It's your doctor simply may not know of all the trials that are available to you. They may know the studies that are in their institution, but they may not know the studies that are in one institution across town. So I think it's on us as patients to keep asking, and if you're not getting much information, then to call a group like the Judy Nicholson and to find out who can I speak with, who can help me navigate the world of clinical trials because I think there must be something. So our message there is it's never too early. And that means from the first diagnosis of there's a something on your kidney, chances are there's a clinical trial that will actually start at that point in time as well. So you can't evaluate a trial that you've never heard about. And you can't evaluate a trial if you've already started a drug. Let's say you've started sunitinib, that might automatically exclude you from a whole bunch of trials. So you have to look at this early and ask about this often. So what I've learned personally, so I did a 3-year study at the NCI, at the NIH in Bethesda, and the care was nothing short of excellent. Expert care, lots of monitoring. I can't speak highly enough, and nothing escaped their attention, including things that I wish they had forgotten about. But so the comment there that you have more trial options early. It gets tougher once you've had other treatments. And you can negotiate a few things. If the physician really does want you on the trial, if you're a good match, I was able to negotiate some MRIs instead of CTs because I've had a lot of CTs. But that's just an example. You can negotiate some of the things that are within the realms. Yes, there are risks in participating, absolutely. There are also risks in not participating, especially in the setting of metastatic disease. We're always taking risks, but it's something to think about. So the hope piece, and I can see one of my blocks has fallen off the screen there with the color, but I do believe we've got every reason to have hope in kidney cancer, that as we look, there's many new treatments in the pipeline. The number of studies going on in kidney cancer is it's overwhelming. So every medical conference, whether it's at ASCO in Chicago or ESMO in Europe, there's study after study being reported. And some of the data looks really good. Some of it we've still got to kind of work out. What we're hoping to see is treatments that offer more effectiveness, so more efficacy, but with less toxicity. So we've reached some new milestones lately where we're starting to see some complete responses for a small number of people, but we need to find a way to do that with less toxicity so that patients aren't suffering as much and not needing the steroids, et cetera. And we're hoping for less invasive ways of controlling disease. So that would be important. What else do I have here? To the improve complete response rates. So as much as everybody has said IO combinations, the data says 9% of patients on that study had a complete response. There's another subgroup that went to 16%, but we need to remember where we are today with approved treatments is somewhere between 9 and 16% are getting a complete response. So that's fantastic. But we need to grow those numbers so that we get to a point where 80% are getting a substantial response. And the last point says, maybe what we're doing is we're turning kidney cancer into a chronic disease. So there'll be more people like me standing here saying, I'm pretty sick and tired of kidney cancer, but I've had it metastatic for 22 years. And it just becomes a treatment journey of doing different things at different times and just getting a handle of the disease, but mostly living a good life in the meantime. So here are the 10 tips that I have stolen from Canada. And now they'll be on video, so they'll all know that I took them from their website, so that's okay. So the first of the 10 was really what I've been speaking about, is to become informed yourself, because there's an awful lot of misinformation out there. So you learn about kidney cancer and its treatment, and you're not going to learn that from Facebook, please. Go to good evidence-based sources. So a couple of the suggestions I have, the AUA guidelines, that's the American Urological Association guidelines, the NCCN guidelines, which is the other US guideline. But these are written by teams of kidney cancer experts. They're peer-reviewed, and they're based upon evidence. So in Europe, we use a different guideline, the European Urological Association guideline. But in the US, these are your national guidelines. And one of them is written in patient-friendly language. You should take a look at these and trust this information and know that most of what you're reading on Facebook is anecdotal at best. And sometimes I think it's really doing harm to spread misinformation and fear-mongering among patients. So the point 2 is to keep track yourself. If you think that any of your doctors is keeping track of everything, they're not. And I think that your best source of having, until we get to full electronic health records, is for you to have, whether it's a binder or a box or something that you carry around with you, but you need to become your own information agent. So, so I take notes at every appointment. I make sure that I'm well prepared for every appointment with column A that says everything is stable and column B that says it's not so stable, and have kind of a plan of what my questions will be in either scenario, just so that I'm not caught, like we say, like a deer in the headlights. And so I don't want to be caught like a deer in the headlights again. I want to be ready with the questions. And then I ask for copies of everything. It drives the doctor's office crazy, but the pathology report, the CT report, the blood lab reports, I want copies of absolutely everything. And I keep those all meticulously filed. And that sometimes stops you having extra imaging. And sometimes it calms the doctor down when they say, oh, look, this tumor grew by 0.5 centimeters. I can pull back, oh, yes, but look at 3 CTs ago, it was actually a little bit bigger, then it shrank a little bit. So I can use my evidence in my file to show more of the longevity of the pattern. So I found it being particularly important to organize myself, especially when the care is a little bit distributed. So if you're getting other doctors doing various things. So I do all of that. And if I'm seeing a brand new doctor, I type up a quick summary of, just so that that doctor doesn't think they're dealing with a normal person, but they're dealing with somebody who's had this for a very long time. And I can do a one-page summary, and that's helpful. So tip number 3 is to be proactive. I think people who are here and watching this video are already proactive by seeking out the information. But it does mean you have to ask questions, and sometimes ask questions that your doctor might not be comfortable hearing. So that question might be, how many of these have you done before, doctor? Or how many patients with my subtype are you currently treating? And if the doctor said, well, you're my only papillary patient, then that would be a note to self to maybe go find somebody who's treating more papillary. So ask those difficult questions, because you literally are putting your life in their hand. And get a good surveillance strategy. Agree upon the surveillance strategy that you can live with, and then stick to that. Number 4 seems like motherhood, although it's probably the hardest thing for any of us to do, is to say follow a healthy lifestyle. And I know we're going to hear more about that, but that means eating well, and it means quitting smoking. Some cancer patients think, well, I've already got cancer, so what difference could it make? But it does make a big difference to quit smoking, even if you do have a cancer. Maintaining a healthy body weight, we all know that's not easy, but obesity is related to kidney cancer, and we should try to do our best. Monitoring your blood pressure, keeping it under control, and regular physical activity doesn't mean joining a gym, but it means walking 30 minutes a day at least, and building on that. So all of those things have evidence, where we're often looking for a silver bullet. What supplement should I be taking? Turmeric? Should I be, in Canada, there's a lot of discussion about cannabis oil. What easy fix could I be taking, when the real easy fix is exercise? There's more evidence on exercise. Number 5 is about being self-aware without driving yourself absolutely crazy, that not everything you feel is cancer, but just being aware of those subtle changes that don't go away. And so sometimes what I do is I just write myself a small little note and say, I'm going to think about this again in 2 weeks to see if that problem is still there. And if it is there in 2 weeks, I'm going to go report that in. If I've got a strange bump or something like that. Because it's really, as a cancer patient, you feel that every cough is a lung metastasis, every headache is another brain metastasis. But so we have to live in that line of being vigilant, but not driving ourselves absolutely insane. So just being aware, and that kidney cancer doesn't usually show up in strange usually it's lungs we hear and bones and liver, et cetera, but we've all known patients where it's shown up in the thyroid, or it's shown up on a finger, or it's shown up on an ovary. It's just a very bizarre disease, so we can't really rule out anything and say for sure that's not kidney cancer. So yeah, I think the kidney cancer I'm dealing with right now is in the armpit. That's not a usual site for kidney cancer, but it is the site for lymph nodes, and lymph nodes are everywhere. So number 6 says speak up. Make sure that you've got more than one doctor looking after you. And I think these surround sound specialists, to find these people who can help you, the psychological counseling has been hugely important, because we have to figure out a way how we're going to cope with this disease. That quite often that in the doctor's office, they focus a lot on the tumors and the measurements, but we're the people when we walk out of there trying to figure out how to cope with all of this information. And the words palliative care, a lot of people don't want to hear them, so I've thrown other words. Sometimes it's symptom management, it's supportive care, it's palliative care. It does not mean hospice care, but it means a team of people who are going to help you through a life-threatening illness. And the evidence would say, you bring those people in early, you actually live longer. So I wouldn't hold that off till the very, very end, but I know it's tough. Number 7 says take care of your remaining kidney or bits of kidney. And there's lots of misinformation out there about what patients do to take care of their kidney. So what we know is, yes, you should drink plenty of water, 6 to 8 glasses a day, but you don't need to drink liters and liters, or I guess you would say gallons. To avoid taking medications that are harmful to the kidney, such as ibuprofen, aspirin, any of the NSAIDs. And then I had to write what else, because this wasn't from Kidney Cancer Canada. But there's some thought that you need to do everything you can to avoid hypertension. You need to try to avoid diabetes, because those are going to be damaging for your kidney as well. And maybe some of the docs after in the room will have other thoughts about how you can take care of your remaining kidney. But I read online patients who are abandoning all protein, who are doing crazy things because they're trying to protect their one kidney. So I'd be interested to see what the doctors have to say about that. Number 8 says knowing your risk, and this is a scary thing, because a kidney cancer is not a kidney cancer is not a kidney cancer. So you can't read somebody who has given up scanning after 3 years and think that's what you should do. So a surveillance strategy is customized to your type of kidney cancer, and yes, that means you're going to deal with scanxiety, and together as patients, we're all going to get each other through scanxiety, that you're going in to get some information to better manage your disease and to stick with the follow-up. That just sticking your head in the sand and saying, well, I'm not going to have any scans because I'm too anxious, it's probably not a really good strategy for the long term. But knowing your risk, and lots of patients who are out there, maybe had kidney cancer a long time ago, really don't have much sense of what their risk is. So number 9 says don't forget the rest of your body, because you might die of something else. So scheduling checkups, we say family doctor, but your usual HCP, and get all the other things done, all the other screenings, et cetera. Along the way, somebody mentioned to me that, oh, well, since you've had one cancer, you're at a higher risk of another one. I said, well, thank you very much. It's just, exactly what I needed to hear. But it's important to have all of those other, whether it's colorectal screening or breast screening or prostate, et cetera, to have all of those done as well, just as if you were a normal person. And to remember that with kidney cancer, there's no 5 years and you're clear. That doesn't exist. There's lots of patients out there who recurred 17 years later, 11 years later. I mean, it certainly does tail off. But, yes, you can celebrate being in the no evidence of disease club, but I would be very cautious about using the word cured, because until somebody's lived a ripe old life and they die at 105, then maybe we can say they were cured. So the last one says, it's really pertinent to being here today, is remember that you're not alone. because there's tremendous power in reaching out and connecting with somebody who is living with the disease, and a caregiver to connect with another caregiver. So I would beg of you to use reliable, evidence-based sources of information, and to beware of pseudoscience and fake medical information that's on social media. There are a lot of well-intended people posting things that they've read about somewhere on a Gwyneth Paltrow site or something like that, and they think, or Dr. Oz, you name it, and they think that this is what all kidney cancer patients should be doing. So please check your sources, and if in doubt, contact a registered kidney cancer patient organization, and we will find the evidence on that and get back to you. But it's really very dangerous in following some of the advice. Sometimes I just have to get off Facebook because it's creating too much anxiety just to try to answer people back and say that that's dangerous. So the last point is to say that life goes on, and in between medical appointments, there's every chance to take a vacation, take a break, to do something else, to read something else that isn't about kidney cancer, and to enjoy life, because it goes on. So I would very much urge, not to focus 100% of your energies on the disease, because you're still here, and life needs to be lived. So in my journey of my 22 years, I've seen my 2 children grow up. One got married last year, and the other one, well, maybe he'll get married eventually. So life has been good, and with kidney cancer, this is the way that I pay it back. So happy to answer any questions or any additional comments.
I know, Jenna, we talked about this together, but I was astounded by that number that there's only 2 to 3% clinical trial patients in the United States. Now, is that, you talked about this, is that just coming from an oncologist or general practitioner that's not being knowledgeable or not getting the information? Or, like, I was blessed with my oncologist who's, younger, not necessarily, but he seemed, pretty knowledgeable and put me in touch with Dr. Peely when he was getting ready to start a trial. So, but the time there were delays going through that, and other than that, that was the only one. And thankfully, my biggest advocate, my wife, went online and found another trial in Fort Wayne. I'm from Indiana, but we went and checked it out and showed it to my oncologist. Like, oh yeah, this I think you could. Made some calls and bing, bam, boom. If we hadn't done our own research. Luckily, I had an oncologist that gave me one option, but that option looked like maybe a few months, and we weren't comfortable. Neither was he waiting. So, and then my wife hadn't found that. Is it just a lack of knowledge, or just willingness to go out and network? Is it just like, hey, I'm, my medical group, I live by them. They're my gang, so to speak, or whatever, and just not willing to share? Or is it just I don't know. It's just troubling to me.
I have lots of thoughts. I'm gonna pass this over to one of the U.S. doctors for a perspective. In our study that we've done, we've just finished a global patient survey, and a huge majority of patients say they were never approached about a clinical trial. And then we asked a second question of those who've never been approached, how many of you would likely have said yes to a clinical trial? And it's right up there, about 98% would have considered it. They're not being asked, and what we're looking at now is where were those patients? So if you first presented in a community center, so in a community hospital that maybe isn't a major cancer center, it seems that there is less likelihood that a trial would be mentioned to you. And especially given that there are therapies, they're FDA approved. This is the standard therapy, take this and go home. So there are some issues specific to the United States why the numbers here are lower, but I don't want to be so brash as to suggest those, but could.
The question was why such a low?
Yes, why is there such a low 2 to 3% of cancer patients in the U.S. who sign up for clinical trials?
Well, that's easy. It's just the heterogeneity of the United States. The care is not organized. I'm been involved with the Society for Urologic Oncology for the last 20 years. And just in the last 5 years are we really developing clinical studies through this group, which is supposed to be the group. With breast cancer, there are, for years there has been a lot of money, many more women involved with breast cancer, for example. With prostate cancer, very few, maybe 20% of the breast cancer. And kidney cancer and other things, it's just where you're showing up. They're coming to their local and they're not getting referred to the medical centers. And even in medical centers, well, this is my study here at the University of Podunk. And I don't want to, this is my study, so this is, I'm not going to share. Well, so the whole thought of multi-center studies, international studies is just coming around. So why? So then you have a worthless study that you spent time in, and with a small group, and the numbers aren't big enough, and so the stats aren't big enough. But I get a publication, and I need this publication. So they're not thinking about that. Mm-hmm. So they're not thinking of the big picture of doing that. So that's the reason why, and so the NCI has the and also the resources of doing this. These are expensive and everything like that. So those are all the reasons why Canada is better organized, why Europe is better organized, and then also databases, and everybody. All the different computer systems are just now coming in to the United States. Oh, but then there are 4 or 5 different computer systems. And so they're not communicating. So it's just, those are all the, if that was the question you wanted to answer, correct, sir?
Yeah, but it can't be that complex. Because my wife went online, she's a medical expert, and found another clinical trial. So, I would think it would be substantially easier for a doctor, an oncologist, urologist to say, oh, if we I'll get back with them on a busy day, and we'll get back with you in a couple of days.
Well, a lot of them are, it's just not organized to that degree, and then having the smaller studies and everything. So it's getting organized in that way. Mm-hmm. And thank you so much for this talk. You definitely made a, as I said, I would love to take this video. When is this video coming out? Can I put this video on my job? I've been at UF, and I'm developing the GE oncology program there, and no website. There's nothing. I'm coming to a ground level to develop this program here at UF Jackson. I would love to take this video and put it in here, and all the stuff that you do. I would love to clone you because you are. Kidney cancer, but gosh, I have bladder cancer patients who just need this. So, but I guess I don't have to clone you because this video will be on, and I'm going to put you into my website.
Yeah, and any of the information we have on the International Kidney Cancer Coalition, we steal from all of the groups all around the world.
I'm going to steal it all.
Steal it away. It's there for stealing. So that's good. And I would just comment, too, that in the U.S., because you have access to off-label treatments, you can combine agents in a way that are not FDA approved, but you can access them off-label, where in other countries you have to do that on a clinical trial. So it is very much to do with the health system differences in the U.S. So if there was a patient, for example, who wanted to do cabozantinib plus nivolumab, that's not an approved combination, but the patient could just get their insurance to pay for it and do it. But that's a loss to the rest of us because we're not collecting the data in that trial. So that combination may never get approved if everybody is just doing. Now, I understand from a patient perspective that you want to do it close to home, et cetera, but as patient advocates, if we can, on all the communities that we're on, if we can get patients to do exactly what your wife did and say, think of a trial first. And if your doctor says, I don't know about any trials, then call a patient organization because that might not be the final answer. And especially with the rare subtypes, so the papillaries, the chromophobes, the collecting ducts, et cetera, we can't just let those patients go home with a prescription. That those patients need to be navigated into a clinical trial. So let's all together play a role in this. And I think patient groups have got a strong role to play. And welcome to the team, Rachel. Okay.
I want to add on that, though, that I think part of the problem with getting people in clinical get the sugar pill and I'm not going to have a chance at fighting this. And that's what they're afraid of. We're fortunate. He's on a trial where that's not, going to happen. So I think it's more education that there are trials you can get on that you don't have to risk getting that sugar pill. Because I know I have had friends who have had family members that have had to make that decision on a clinical trial and take that 50-50 risk when they were probably even more severe than Mart on their health.
In metastatic kidney cancer, I can say with confidence, in metastatic, nobody gets a placebo. Unfortunately, there are some trials in earlier stage kidney cancer where placebo has crept in, intravenous placebo, and as a patient advocate, I have spoken out very strongly against those trials. And there are now some trials in that setting where there is no placebo. But again, that's where we have a voice as patients to say that that's not acceptable to put 50% of those patients on IV placebo. It's not acceptable.
If I can say, it's really the studies are older clinical studies, it's really the standard of care of therapy. Thanks. It's really the standard of care which is accepted, and then the newer, so no one is really on that placebo anymore. And then also there are safeguards putting into the clinical studies also that if there's not a progression, then you stop that and you flip, and they're really flipping things so that old thoughts of placebo or not getting anything, I don't think are relevant at this day and age.
Yeah, those thoughts are still
question.
out there. I
Yeah.
agree. They're still out there in the community, and
Sure.
certainly within some cultural communities, there's a sense that we will be experimented on in
Yes.
an unfair
Guinea
way.
pigs. We're
So
just guinea pigs.
we have to work against that and say this is actually tomorrow's care today, and it's excellent care, and it's a chance to kind of leapfrog ahead a little bit and to save some of your other options for down the road. So I think that's a job of messaging we all need to do. Okay?
Do you think as far as from your experience dealing with patients, that a lot of these caregivers or patients are starving for information? Or do you think there's in regards to clinical trials, or do you think it's a bit of head in the sand, like you get this, life-altering prognosis, and you're like, whatever you think, doctor, I don't want to think about it, versus saying, I need more information, I'm starving. Because for example, when I started Dr. Peely's clinical trial, they gave the protocol page after page of side effects, common, not so common. And my wife and I, we immediately started going through and Sheila, our trial nurse, who's great, she was kind of, oh yeah, by all means, take a few minutes to read. She came back a few minutes, no, we're not done yet. And she's like, finally, we had some questions, she answered, she's like, I'm sorry, I'm just not used to, most people just sign immediately and don't even take the time to go through the information. We're like, well, yeah, we're probably going to do this, but we both want to know ahead of time I don't want to wake up tomorrow and be like, oh, hey, my whole body is shutting down. Is that pretty common with people? I mean, from what you found, patients saying, I don't want to know. The less I know, the better off, or I guess it depends on personality type too, perhaps?
Yeah, you've got some people who don't want all of that information, but, if I can say, you seem like you're both well-educated, well-read people who would read all of that information. Some people don't even get to the point of asking about a clinical trial. And there are others, just sign me up. So I think where there's danger is where there is a lack of information on a topic, that void gets filled with poor information. So when it comes down to renal biopsy, which we discussed this morning, the amount of misinformation out there about renal biopsy, I just read the other night that the tumor's going to seed, you're going to bleed, there's no use for it. My doctor said you shouldn't have one. And this is patient to patient going on, and the information they have might be 10 years old. But so I think that's the danger of some of the unmoderated Facebook communities. I think it's great for support, but when it comes to medical information, point to videos like the ones that we've just shot today to say, this is the current information. Because it scares me a little bit that people are being put off of biopsies or being put off of trials because their great uncle Harvey joined a trial and he died. but that might have been 30 years ago for a different disease with a different treatment. It's not relevant. But there's a lot of that fear-mongering going on.
Deb, a thought I have, having listened to a lot of patients and been involved peripherally. Today, we have the A-team of doctors here. There's no question these gentlemen are going to voice this. But like in any hierarchy of professions, you've got your Bs and your Cs and so forth. I think clearly if you go to an A-team physician for care, you're going to hear about clinical trials and current treatment. But if you go to a doctor, and in podunk as the term was used, who might be a urologist or an oncologist working with such a small segment of our population, they may very well not think of talking about clinical trials, which comes back to your point of messaging, of getting these things out to people who are in whatever city, that they can pull up these videos and learn more about the clinical trials and other advanced forms of treatment.
Okay.
Would you agree with that?
I would agree, and if you're not sure if your doctor's a kidney cancer specialist or volume, you can ask. You can also look online, and I would look to see what publications they've been part of in renal cell carcinoma. So what conferences have they attended and perhaps presented at, what their publications are. And if they're a younger doctor, they may not have published a lot, but are they part of an institution that has a high volume of kidney cancer cases? Those are all good signs for me that you're in the right place. I have no idea where podunk is. But if we were dealing with a general urologist in this place called podunk, I would think that perhaps might be an okay situation for some straightforward kidney cancer cases, but I'm a big believer in getting a second opinion before you have a major organ taken out. Okay. Okay, am I released? Thank you. Thank you.